Welcome back to part 2 of our video presentations on the basics in interpreting cardiopulmonary exercise tests. In part 1, we covered the types of respiratory limitations that may occur and how to differentiate and interpret them. In this video presentation, we are going to examine the non-pulmonary physiologic limitations to exercise. Though we usually tend to think of these findings as being of cardiac origin, because there are many non-cardiac conditions that can give similar results, it is important to understand the clinical context in which these abnormalities can occur. We need to understand what we mean by the term anaerobic threshold, or AT. This is the exercise VO2 above which there is an O2 supply to demand imbalance in the muscles, causing a net increase in the lactate to pyruvate ratio above what would be predicted from aerobic metabolism. As shown in this equation, this excess lactate is buffered by bicarb, which is then converted by carbonic anhydrase to CO2 and water. The body then eliminates this excessive CO2 by increasing the minute ventilation, or VE. Some authors recommend using a 9-plot page of graphs to interpret a number of specific variables during exercise, including for identifying anaerobic threshold. I'm not a particular fan of this method, since these postage stamp size images tend to be hard to interpret when examined individually. Many authors recommend the V-slope method for identifying anaerobic threshold, shown here, which plots the change in slope of the minute ventilation, or VE, against the VO2 that occurs at AT. I personally do not find the V-slope method that reliable, except in patients that are normal, which we do not see too often in our lab. With the computer technology available today, and the ability to overlay and manipulate data in so many different ways, I would like to show you how we like to look at patient data, which I feel often makes it easier to understand and to identify AT. I recommend picking 4 variables that change their shape or slope at the point of AT, and plot them on 4 different y-axes. First, we're going to look at a breath-by-breath plot of the VE to VO2, or Phenyl Tor Equivalence for oxygen. I've created artificial patient curves to make my points a little clearer, but then I will show you actual tracings of patients to better correlate this information. The normal shape for the VE to VO2 tracing is that early during exercise there's a downward slope. This is because the subject's O2 consumption is rising more rapidly than their minute ventilation is increasing. When the patient reaches anaerobic threshold, or AT, the rise in serum lactate drives the minute ventilation, or VE, to increase in order to get rid of the excess CO2, which causes the minute ventilation, or VE, to rise more rapidly than the O2 consumption. This causes the slope of the curve to start turning upward. By definition, AT is the lowest point on this curve before it starts to rise. The second tracing we like to examine is the Phenyl Tor Equivalence for CO2, or VE to VCO2, which behaves a little differently at AT, shown here in the red dots. When anaerobic threshold is reached, the tracing may go flat for a short period of time that we call isocapnic ventilation. This occurs because after the onset of AT, the lungs have some compensatory capabilities for buffering the lactic acid, blowing off the excess CO2. Soon, however, the acidosis generated is greater than the ability of the lungs to fully compensate, resulting in the minute ventilation, or VE, rising excessively in relation to the VCO2, causing the slope of the VE to VCO2 to start to rise rapidly, just like the VE-VO2 tracing. A third tracing we find useful is the measuring of the P-end tidal O2, or the partial pressure of O2 at the mouth at the end of each breath. At anaerobic threshold, we start to see a step up or rise in the P-end tidal O2. The reason for this is that the air in the lungs contains 3 gases, nitrogen, oxygen, and carbon dioxide, but because nitrogen is not utilized by the body, the concentration remains constant in the air and in the alveoli. The remainder of the gas concentrations is determined by the partial pressures of CO2 and O2. As a subject becomes progressively more acidotic above anaerobic threshold, driving up their minute ventilation, or VE, in response to the increasing metabolic acidosis, this causes an alveolar hypocapnia, or falling in the alveolar PCO2. In order to maintain 1 atmosphere pressure in the alveoli, to compensate for the decreasing alveolar PCO2, which can fall into the 20s, the partial pressure of O2 rises in the alveoli, which is reflected by an increase in the end tidal PO2. The fourth plot we will look at is the respiratory exchange ratio, or respiratory quotient, we will call RQ for short. This is the ratio of the VCO2 to VO2, or the CO2 production to the O2 consumption, that is measured at the mouth. We are often taught that in the resting state this value is approximately 0.8. When metabolizing carbohydrates and protein, we produce around 1 CO2 for every O2 consumed. But because there is some background lipid metabolism that is much more efficient, producing less CO2 for each O2 consumed, the value of R is a little lower. Well, as we would expect, when we cross the anaerobic threshold during exercise and start buffering lactate, the ratio of VCO2 to VO2 starts to also rise rapidly. If you can draw a line that goes through all of these points that we have just identified, you can feel fairly comfortable that you have identified AT correctly. Now I'm going to show you a couple of actual patient tracings. In this first patient, we can see that where we are drawing the line for anaerobic threshold, the blue dots representing the ventilatory equivalence for O2, or the VE to VO2, reach the lowest point before starting to go up, while the tracing for the ventilatory equivalence for CO2, or VE to VCO2, is plateauing, reaching isocaptic ventilation. And at the same time, the respiratory quotient, the turquoise points, start to increase, while the P-end-tidal O2, in purple, starts to drift upward. In the second case, we have a trained runner who hits his cardiac output limits of maximum achievable stroke volume and heart rate, and cannot increase his VO2 any further. Again, we can draw a line that clearly identifies anaerobic threshold, passing through the lowest point of the VE to VO2 in blue before increasing, while also passing through the start of isocaptic ventilation shown in red. The line also passes through where the RQ begins to increase in turquoise and the P-end-tidal O2 starts to rise in purple. Determining if anaerobic threshold is reduced or abnormally low is not always clear-cut. The VO2 at anaerobic threshold is reported as a percent of the predicted maximum VO2. But the predicted VO2 can vary depending on the population studied and their level of fitness, so one needs to choose their predicted values accordingly. There is general consensus, however, that an AT that is below 40% of the predicted VO2 max is always below the lower limit of normal no matter what age. Keep in mind, though, that as individuals age, above the age of 25 to 30, for every decade, the lower limit of normal probably increases by approximately 2%. So that by the time a person reaches 75 to 80 years of age, the lower limit of normal AT is closer to around 50% of their predicted VO2 max. This is because predicted VO2 declines more rapidly with age than AT, so the AT lower limit of normal becomes a higher percentage of the predicted maximum. Once we have established that the AT is reduced, we then need a way to systematically evaluate for the various causes of a reduced AT. Because these many different causes can give similar findings on exercise testing, one needs to know the patient's history and as much laboratory testing as is available to narrow down the possible causes for the reduced anaerobic threshold. When I am teaching fellows, I tell them to pretend that they are a red cell, and starting in the left side of the heart, follow that red cell all the way around the circulation until they get back to the left side of the heart again. For example, starting at the left ventricle, we are all familiar with the diseases that can reduce cardiac output, such as cardiomyopathies, valvular disease, ischemia, and conduction failure, which can reduce delivery of oxygen to muscle, reducing oxygen consumption, thereby reducing AT and peak VO2. As we move further out into the arterial system, blockage in the circulation, such as claudication, can decrease O2 delivery to the tissues. In this particular situation, the patient may describe classic pain in the legs from the ischemia, helping identify the cause of the reduced AT. I also throw anemia in the differential at this point. Obviously, if someone has a very low hemoglobin of 8, they're going to have a hard time squeezing out a normal AT and peak VO2. The actual effect of low hemoglobin on AT and peak VO2 are complex, and the body does have mechanisms to compensate for mild degrees of anemia. As we move out into the periphery, we have the metabolic and myopathic diseases that can interfere with the metabolism of O2 to create ATP, causing generation of inappropriate lactate at low levels of work. Neurologic diseases can also reduce AT. Whether this problem occurs centrally or at the level of the synapse of the muscle, if there are suboptimal numbers of muscle fibers firing, the ones that are working will certainly not be able to achieve a normal VO2. Moving over to the returned venous side of the circulation, If one has severe obstruction of venous return, it only makes sense that if one cannot return the blood to the heart to the point that the cardiac output is ultimately reduced, this will also eventually reduce O2 consumption. I place diseases of end organ failure on this side of my diagram because when you have severe renal or hepatic failure, the body is producing all kinds of toxins, such as in states of acidosis, that impair the normal metabolism of O2 and other metabolites that can shift lactate threshold, producing excessive levels. Pulmonary vascular diseases we are all familiar with. Their effects are complex. Not only do they reduce cardiac function by their effects of plugging up the pulmonary vasculature, but in addition, there are also the effects caused by right ventricular failure that, when severe, eventually cause compromise of the intraventricular septum, impairing left ventricular function and reducing cardiac output. And of course, there are all of the pulmonary parenchymal lung diseases that cause hypoxemia, whether obstructive, ILD, or chest wall mechanical or neurologic restriction. Keep in mind that when these are present, the AT is not reduced due to hypoxemia unless the patient is actually hypoxic at the anaerobic threshold. If AT is reduced and hypoxemia is not present at that point, and may be secondary to complications of pulmonary disease, such as pulmonary hypertension or cardiac pump failure. And lastly, we cannot forget about the little stretch of the circulation between the lungs and heart, the pulmonary venous system. Though rare and difficult to diagnose, pulmonary veno-occlusive disease does sometimes occur and can be present with dramatic symptoms of dyspnea and what appears to be reduced cardiac function. Examining the patterns of the tracings for the cardiac parameters can be just as useful as when we examine the graphs for the respiratory patterns. Remember how we said we can explain all aspects of exercise physiology by the Fick equation, and we showed how the cardiac output equals the heart rate times the stroke volume? Well, assuming that a patient is not markedly anemic or has a hemoglobinopathy to reduce the O2 carrying capacity, and also assuming that the patient doesn't have some kind of weird mitochondrial myopathy or hereditary metabolic disorder to markedly alter the mixed venous O2 return, we can assume that this part of the equation remains relatively constant. That means that VO2, or oxygen consumption, is proportional to the stroke volume times the heart rate. And if we divide both sides by the heart rate, we are left with the VO2 divided by the heart rate being proportional to the stroke volume. We call this value the O2 pulse. Both the VO2 and heart rate are easily measured during exercise testing, and this ratio can be plotted on a graph to reflect what the stroke volume is doing during exercise. The first example I'm going to display is a tracing of a trained runner. The blue curve shows the O2 pulse progressively rising as the work rate incrementally increases, plateauing when he reached the limit of his stroke volume at a VO2 of 120% of his predicted maximum, while the heart rate in red increases linearly to 100% of his predicted maximum. And the second example is a patient with a cardiac pump limitation. This patient's O2 pulse, shown in blue, plateaus at a reduced VO2 around 60% of their predicted maximum oxygen consumption, suggesting a stroke volume limitation, while the heart rate in red tries to compensate by rising rapidly to 95% of predicted. And the third example is a patient with severe pulmonary hypertension. In this subject, not only does the O2 pulse plateau prematurely at a reduced VO2, but the stroke volume actually starts to fail, decreasing in the latter stages of exercise, with the heart rate markedly increasing, trying to compensate. Again, it is important to be reminded that there are other non-cardiac factors that can decrease the VO2 besides a reduced stroke volume, and one needs to consider these other conditions that can alter the right side of the Fick equation that we showed in the previous slide. Another useful plot to examine is the slope of the VO2 to work rate, which can only be plotted when using a cycler ergometer rather than a treadmill. The lower 95% confidence limit of normal for both men and women has been shown to be 8.5, with values below that being indicative of cardiac pump failure. But remember, one needs to exclude the other causes for reduced VO2 such as severe anemia, metabolic or neuromuscular diseases. Often one comes across a slope of the heart rate divided by the VO2, with a value of greater than 50 often being cited as being abnormal. The higher the value, the greater degree of cardiac pump failure. Keep in mind, this is really just the inverse of the O2 pulse, so this has all the same causes for being abnormal as the O2 pulse. Also, in subjects that are deconditioned, one can see an excessive heart rate for level of O2 consumption if they stop exercise early at a suboptimal VO2. The VO2 in milliliters per minute per kilogram is the last topic we will cover. This value is used to determine prognosis in lung resection surgery, as well as determining degree of wellness and planning in pulmonary rehabilitation. The cardiologist uses this value in assessing patients with chronic cardiac failure and their ability to withstand cardiac transplant. There has been considerable variation in the range of values obtained as cutoffs, in part because of confusion if studies correct for ideal body weight or not. If studies are performed in very obese individuals, considering adipose tissue does not metabolize much O2 during exertion, the VO2 when corrected for obesity can be considerably lower than for ideal body weight. In our laboratory, we report both of these values. The prognostic significance of this value is complex and varies depending on if the patient is on beta blockers or had resynchronization therapy. The one caveat that we often see that needs to be mentioned is how often we see subjects that achieve a normal VO2 but at almost zero workload. When this is present, it is always in one of two conditions. Either they are markedly deconditioned and or they are morbidly obese. The latter makes sense if one thinks about it. If one is using a cycle ergometer incrementally increasing the wattage on the pedals, it is not measuring the wattage from the additional body mass. For example, if someone is 150 pounds overweight, that's approximately 4 extra suitcases they are carrying on their body and their legs, and the cycle ergometer is not recording that additional workload. Let's first examine how the VO2 per kilogram is used by the pulmonologist for assessing a patient for possible lung resection surgery. Guidelines have been published by the British Thoracic Society, the European Respiratory Society, and the American College of Chest Physicians. And though there is considerable overlap between them, there are also significant differences. In the ACCP guidelines, the first step in their algorithm for choosing patients that should have a cardiopulmonary exercise test is to select out those with an FEV1 less than 80% of predicted, who have an FEV1 less than 1.5 liters are being considered for lobectomy, and those less than 2 liters being considered for pneumonectomy. And in this subset of patients, then estimate their percent predicted of postoperative FEV1 and diffusion using tools such as split lung studies. If either of these values is less than 40% of predicted, then a cardiopulmonary exercise test is recommended to obtain the VO2 per kilogram. As an aside, if their pulmonary function test results are greater than these values, they are at a lower risk and do not need a cardiopulmonary exercise test. And at the other end of the spectrum, if their pulmonary function tests are horrible, at less than 30% of predicted, there's no point in doing a cardiopulmonary exercise test because they will not have enough lung function to survive a lobectomy, let alone a pneumonectomy. Because we are only discussing the value of the VO2 per kilogram from cardiopulmonary exercise testing and not the other aspects of the guidelines, we will not discuss these other groups any further. We know that patients with a peak VO2 per kilogram less than or equal to 10 are at very high risk. Their prognosis is poor, and other modalities should be sought. At the opposite end of the spectrum, those with a VO2 per kilogram greater than or equal to 15 are at relatively low risk for surgical morbidity and mortality. It's in this gray zone of 10 to 15 milliliters per minute per kilogram that we struggle. The guidelines tell us that they fall into a high-risk group, but we also need to consider how good of an effort during exercise a subject is able to achieve, and if we push them a little harder, could we have gotten the VO2 per kilogram into this lower risk range? I firmly believe that cardiopulmonary exercise testing should only be supervised by those with experience, who are aware of the subject's predicted pulmonary and cardiac limits to be able to recognize when a patient has performed an optimal test rather than quitting due to discomfort from lack of regular exercise. Some of the tools that cardiologists use in interpreting exercise tests, we could also utilize in interpreting pulmonary exercise tests assessing a patient's effort, which we will discuss next. The cardiologists use the cardiopulmonary exercise test in assessing prognosis in those with chronic heart failure. The cardiology literature is in agreement that a good VO2 per kilogram is a good prognostic indicator, but their values are a little bit higher, starting at greater than or equal to 18 milliliters per minute per kilogram, not taking into account pulmonary function values since they are not using their testing for lung resection consideration. At the other end of the spectrum, a VO2 per kilogram of 10 or less again conveys a pretty grim prognosis. However, they recognize that a patient performing a suboptimal test or poor effort can give a reduced value as well as bad disease. They use the RQ, or respiratory quotient, which is looking at the VCO2 divided by the VO2 to help sort this out. Achieving a value of greater than or equal to 1.15 is an indicator that a patient has demonstrated an adequate effort for assessment and exercised well beyond their anaerobic threshold, achieving a near optimal VO2. If their RQ did not achieve this value, then we can say that maybe they are not as high a risk because their effort was not optimal, but we cannot be sure. We have some tools to help us assessing in this in-between category as well. Their in-between range is from 10 to 18 milliliters per minute per kilogram. The VE to VCO2 consists here and has been studied extensively in patients with pulmonary hypertension and chronic congestive heart failure. We showed in the pulmonary interpretation part of these videos how this value can be elevated not only in abnormalities of dead space ventilation, but also in excessive hyperventilation states, such as can occur when there is excessive metabolic acidosis driving minute ventilation. To help stratify patients with a VO2 per kilogram in this in-between range of 10 to 18, if they achieve a peak VE to VCO2 ratio of greater than 34, studies have shown this conveys the same morbidity and mortality as patients who have a VO2 per kilogram of less than or equal to 10. However, if their peak VE to VCO2 was less than or equal to 34, they have been shown to fall into a mild to moderate risk category from the cardiac standpoint. And hopefully this gives you a good bird's eye view of how to look at the VO2 per kilogram. Now, to give just a quick overview of what we have talked about, we first demonstrated how to identify the anaerobic threshold. We showed how if the VO2 at AT is less than 40% of the predicted maximum VO2, it is abnormal, but also that the predicted percentage value increases with age. We showed you how there are many causes for reduced AT, and that one needs to have an understanding of the clinical history while systematically going through the categories of possible causes to determine if they may be present. Multiple causes may coexist simultaneously. We discussed how the O2 pulse is an indirect measure of stroke volume of the heart and showed examples of how the O2 pulse tracings plotted along with the heart rate can give a visual display of the cardiac function. And we also showed how the inverse of the O2 pulse, the change in the heart rate over the change in the VO2 from rest to peak, when excessive, can suggest heart disease as well as deconditioning. The slope of the VO2 versus work throughout exercise has also been shown to be an indicator of pump failure. The lower limit of normal is 8.5 in the absence of other conditions such as anemia and other metabolic disorders. And we also gave a quick overview of how the VO2 per kilogram can be used as part of the evaluation in patients with severe lung disease to assess surgical risk and in cardiac disease to assess risk of morbidity and mortality. And as a final comment, though we did not dedicate time to this subject since it is an entirely different series of lectures, we need to mention the importance of making sure one carefully monitors the electrocardiogram of each patient throughout exercise for specific electrical abnormalities that may help to explain the patient's symptoms. We find in our lab most patients with coronary artery disease are discovered by other more directed testing prior to the need for cardiopulmonary exercise testing.